Welcome to the real, the free. It's authentically Amy, come talk to me. Love, sex, truth, no shame inside. We're getting deep, and it feels so right.
Hey sexy besties, welcome back to Authentically Amy. I'm Amy, a certified sex and relationship coach. And with me today is Dr. Sebastian Perez Martinez. And we are gonna be talking about midlife magic. What do I mean by that? Well, we're gonna be talking about perimenopause and menopause and its effect on sexuality. So let me introduce Dr. Perez Martinez. He is an endocrinologist in South Florida. He completed medical school at the University of Puerto Rico. He did his residency at the University of Miami. He did an endocrinology fellowship at Vanderbilt University. He's double board certified in internal medicine and endocrinology, and he's a member of the North American Menopause Society. So obviously he knows a lot about this stuff, and we're excited to dive in and hear what he has to tell us about it. Just a really quick roadmap of where we're gonna go today. We're gonna talk about perimenopause and menopause, symptoms of those changes of life that can affect sexuality. We're gonna talk a little bit about desire and how that might play a role in decreased libido that can happen during this stage of life. And then we're gonna give you some tips, tricks, treatments, and other things so you have something you can take away and use. All right, so Dr. Perez Martinez, I'm gonna call you Dr. P if that's okay.
Totally fine.
Okay, so can you just kind of briefly let everyone know, what are we talking about? What's perimenopause? What's menopause? What does that mean? What are we talking about here?
All right. Well, first of all, thank you for having me, Naughty Amy. In terms of the terms that we are going to be using, it's very important for us to know specifically what they mean. We'll start out with the perimenopause and then we'll eventually go to menopause, but I want to talk about the actual age where we kind of look at for these terms. It starts around the age of 40 to the age of 58, so that entire kind of range is where most women will undergo menopause.
Can it start earlier for some women?
It can start earlier for some women. That is typically referred to as primary or premature menopause. And so at that point, when you get around the age of 45, if you get it before that, then that's called early menopause. Most women undergo menopause around the age of 49 to 50. If it occurs after the age of 54, then that's termed late menopause. In terms of perimenopause, the peri in front of it just refers to kind of around menopause. And so during this time, it'll happen before menopause and it'll lag 1 year after the actual menopause. Menopause is defined as 12 months without an actual cycle. So menopause can only really be diagnosed after that. There's another term called menopausal transition. So during this time, it encompasses the perimenopause, but it stops at the menopause, okay? So in terms of what to look out around these things, or how do we define or diagnose someone with perimenopause, it'll be determined by either one, an irregular change in menstrual cycles. All of a sudden, instead of every 28 days, you have them every 35 days. All of a sudden, you miss one cycle or you miss 3 cycles. And then it kind of starts all over again. In terms of these symptoms, you can have some symptoms.
I have a quick question. So what is happening that's causing the irregularity with cycles and things like that? Like what's changing in women's bodies at this time?
The answer is a lot.
Well, give us some examples. What's going on?
In terms of the perimenopause, we are going to focus mainly on the female hormones, the estrogen, the progesterone, to a certain extent on testosterone and DHEAS from the adrenal glands. The issue is that, and in order for us to understand, I'll kind of explain what happens before we're even here. Let's assume a woman has normal monthly menstrual cycles. During this time, around every 28 to 30 days, the estrogen levels are going to start to go up after they have an actual episode of bleeding. That is stimulated by the FSH, or the follicle stimulating hormone. The estrogen levels will reach a certain point at which that will trigger then ovulation, and that is due to an increase in the luteinizing hormone, or LH. That'll go down. And then at that point, if you get pregnant, those levels kind of remain constant. If you don't, the progesterone that started going up, which is the other hormone, will go down if there's no fertilization. And then that decrease in progesterone, or that withdrawal, is what causes the actual bleeding every month, right? So it's a normal change every month. When you get around the perimenopause, what is happening is that the ovaries that were working perfectly well for the last 15, 20 years, they start to give out. And then their actual storage of follicles starts to diminish. During that time, what regulates cycles is the pituitary gland. So that kind of sits right here where my fingers meet, and it regulates it by the secretion of the FSH and the LH, which are the follicle stimulating and the luteinizing hormone levels.
So a gland that's up here is what's regulating the hormones in your ovaries?
Correct.
That's fascinating. I never knew that. I actually thought it was coming from your ovaries itself.
The pituitary gland is considered the master endocrine gland, so it regulates your thyroid, your adrenal, the ovaries in women, testes in men. During this time where the ovaries are not working as well, the pituitary gland's job is to make them work better. And during normal circumstances, it will do just that. However, during this time, it's slightly inappropriate because what happens is the FSH goes higher than normal. And then the ovaries are going to respond by secreting a lot more hormones than they should.
So in perimenopause, this is before menopause, your hormones actually can go up.
Yeah.
If I'm understanding, like generally they're going down as you get toward menopause, but you can have some times when it's like this, like up and down.
Correct. That is exactly what it
Okay.
is. If you have before perimenopause here, you'll have a monthly cycle like this. During perimenopause, if we were to draw it on a graph, it'll be more like this, right? And then after menopause, they'll stabilize again, but at this point, they'll be consistently low. During that time, what is happening is because of the relative decrease in estrogen, the FSH will go up. That will lead the ovaries to secrete a lot more estrogen than they should, and essentially leads to an event called loop or luteal out of phase event, where essentially you have an increase, a surge in estrogen. And so during these times, you can have symptoms of excess estrogen. You have breast tenderness, breast pain, you can have migraines, you can have an increase in your uterine fibroids, you can have an increase in the endometrial hyperplasia. So the endometrium is the lining of the uterus, and hyperplasia means increase. And so you have those episodes, and then you also have episodes where the estrogen kind of goes down. And then at that point, you'll have symptoms of estrogen deficiency. And so these will kind of change every so often, essentially. And these fluctuations in the hormones are what lead to the fluctuations in the symptoms that women will most likely have. And yes, they can be due to excess estrogen or low estrogen. So that's why these symptoms are so kind of all over the place, essentially.
Interesting. And so what symptoms also is it causing that might have an effect on like women's sexuality, for example?
In terms of the sexuality, the main two things that happen are one from a systemic standpoint. So you will have more than likely a decrease in libido. So that is a decrease in desire.
And what's causing that from the hormone perspective? Because obviously I can talk about it from the desire perspective and a sex coach, sexologist perspective, and we'll get there probably, I'm sure, today. But what's causing that from the hormone perspective?
That is due to the relative decrease in the estrogen levels, and then also probably a decrease in the total testosterone levels. So we do know that testosterone, for example, is around half when you're around 40 to 50 as it was compared to when you were 20. So those two decreases in those hormones have a huge effect in terms of your desire for any sort of sexual encounter. The other big one is in terms of the genital area. So at that time, when we have a decrease in the estrogen, you will have a increase in what we refer to as the genital urinary syndrome associated with menopause. And this is secondary to the decrease in estrogen. Genital urinary syndrome, and it is characterized by thinning of the vaginal wall and essentially an increase in symptoms associated with either a sexual encounter or symptoms associated from a urinary standpoint, such as frequency, urgency, incontinence, pain with urination, burning with urination, all these things.
And so the thinning and all those things, obviously that plays a role in sex, right? Because it can make sex more painful, I'm assuming. We know there's a decrease in lubrication that's happening. So is that also caused by the lower estrogen and progesterone levels?
Correct. So mostly due to the lower estrogen levels.
Okay. And so there's a lubrication issue. You mentioned painful urination. What about infections? Is there a correlation there as well?
There's a big correlation. There's a known increase in the risk for recurrent urinary tract infections in postmenopausal women. There's very good evidence behind that, and that is one of the main reasons why we're a lot more open to treating this now, because we know that it has a huge financial impact in the healthcare system, around $6.6 billion a year in terms of the cost associated with treating recurrent urinary tract infection in women. And we have to think about not only 50 or 60s, but 70s, 80s, 90-year-olds who have very complicated urinary tract infections. Definitely one that is associated with the decrease in the estrogen. You can also just have vaginal yeast infections as well.
I guess so the drop of estrogen is causing the infection, but like, why is that? Just so people can understand, like, what is the correlation between lower estrogen and increased infection?
That is secondary to the effect of estrogen in the vagina and the vaginal tissue, and it has to do with the actual pH that is maintained by the vaginal tissue. When the estrogen levels go down, then the tissue cannot do that, and that then increases your risk for having the urinary tract infections.
And then I've also read like women's sexuality, and maybe this is more aging than menopause specific, but like if you have obviously like cardiovascular issues, I don't know if that's linked to menopause or just aging in general, that can also affect your sexual functioning, because obviously when you're having sex, there's a lot of cardiovascular things that are happening, right? Because the blood is all going to the genitals, and that's how you become aroused, and that's right how you can experience orgasm and all of those things. Is there a link between that and the perimenopause or menopause, or is it just more aging focused?
Both.
Both.
So we definitely know that with aging, yes, there's an increase in the cardiovascular events. There's also an increase in the cardiovascular events in menopause women. So that is a very huge topic in terms of discussion. Does hormone therapy prevent or decrease the risk of those cardiovascular events from happening? Or does it increase the risk for those things kind of happening? So we don't really have a good answer as of right now. We do know that it probably doesn't increase it, but we don't know for sure.
Interesting. So then a couple other symptoms I was curious about, like obviously mood swings, right? That's, I think most women, that's one of the things, maybe the women themselves, but maybe their partners complain about during perimenopause and menopause, is people having mood swings. That's certainly, hot flashes we hear about from everyone. I don't know how much really hot flashes plays a role in sexuality, because you're probably gonna be hot. If you're doing it right, you're gonna be hot either way, right? But I think for the mood swings, right, that's obviously gonna play a role in your ability to connect with your partner, ability to have fulfilling sex. So where's the mood swings coming from?
So I would say, I would focus and I would just kind of talk on both the vasomotor symptoms and the mood swings. The hot flashes, do they directly affect your sexual function? Probably not. Overall, would they more than likely affect your mood or your desire? Probably. We know that vasomotor symptoms are present around 21 million females, around 1.1 billion females worldwide, and it is probably the most common cause of women seeking actual therapy from a menopause standpoint, either hormonal or non-hormonal. So again, do they affect it directly? Probably not. Overall, more than likely. Those are termed the hot flashes. Those are defined as kind of these episodes 1 to 5 minutes long that essentially feel as a heat wave, mainly in your chest, neck, and upper area and head. There's a very good FDA panel a few weeks ago with a bunch of experts, one of them being a neurologist whose research is mainly on the effect, or in other words, or better, lack of estrogen in the actual brain, and how that lack of estrogen in that system is the one that predisposes you to having these hot flashes. In terms of what we know now, we know that systemically, that's probably not the cause of why you have hot flashes, as in the decrease in the estrogen, because not all women have it. It's more of an actual issue with the thermal regulation in the hypothalamus, secondary to the presence or absence of estrogen. In terms of the mood swings, you mentioned if the partner's gonna actually bring it up versus the actual patient. From my experience, patients have pretty good insight on this, and they do know when their mood is affected. They do know when they're a little bit more irritable. They do know when they're a little bit more anxious, when they're a little bit more depressed.
What's causing that, like physiologically?
So physiologically, it all kind of goes down to these wide fluctuations in your hormones of the ovaries trying to do their job appropriately or inappropriately sometimes.
I have a question, going back to the hypothalamus thing. So this is a personal question, but I think other people might be able to relate, which is for me, like just hit 40 and probably going through a lot of the perimenopause, I'm always cold. Could that, is there such a thing? Like, do patients complain about like the temperature regulation, right? The flip side, you're saying it's a temperature regulation issue, which could be the hot flashes, but do other people complain like I'm cold all the time and I never used to be cold? Or is that am I just weird?
I want to answer that question. But in terms of do females who are in the perimenopause or menopause range, do they experience more cold intolerance than other females? I would say probably not.
Oh, okay.
In terms of how that can happen, there is an association between thyroid disease and during the perimenopause and menopause, and that is just due to the fluctuations in estrogen, which affect the actual thyroid levels, free versus total thyroid levels. Clinically, cold intolerance is more associated with having low than normal thyroid levels.
So someone, if you're cold, you should probably go get your thyroid checked. That's what I'm hearing.
Yes.
All right, good. So in terms of other symptoms that might occur for some women during perimenopause and menopause, let's talk briefly about weight gain, right? I think that's something a lot of women complain about. Obviously as you're aging, it sometimes can be harder to lose pounds. Is there something physiologically happening during this stage that is preventing women from either losing the weight they want to lose or gaining weight? And what's causing that?
I will answer this in two ways. First one is based on kind of what the studies have shown. And I say this objectively, but based on the studies, there isn't an actual mechanism where the hormonal fluctuations in perimenopause and then the decrease in estrogen in menopause will lead to weight gain. They've also done studies in women who have been given either estrogen alone or estrogen and progesterone versus a placebo group, and they haven't found any significant difference between the two groups. In terms of subjectively, and from my experience, I like to kind of compare it to testosterone in men, right? So testosterone or low testosterone in men does not directly cause weight gain. What it does do, similar to estrogen in women and the testosterone, which is gradually declining in women, it leads to a decrease in spontaneous or purposeful activity. It leads to an increase in sedentary lifestyle. It leads to a decrease in lean body mass and then an increase in visceral fat. So all of these things combined, all of those things can definitely impact your metabolism to the point that doing the same things that you were doing before, your weight can go up a little bit, but then again, not directly due to the hormones and more directly due to all the other things.
Well, and probably due to some of the symptoms, right? Because like another symptom I think a lot of women complain about is like muscle and joint pain, right? For example, so if every time you go to work out or do something, you're like in constant pain, I could see why maybe you wouldn't be as active as you maybe were before.
Yes.
Or if you're having hot flashes, it could be uncomfortable to then go outside and go for a hot run. Right.
Especially here in South Florida.
Yeah, especially in South Florida. It'd be ridiculous.
I will say, in terms of the arthritis that you mentioned, we also have really good data that shows that the decrease in estrogen is associated with a decrease in the cartilage tissue and an increase in the inflammation. So estrogen does have anti-inflammatory properties. So we do see a correlation of the decrease in estrogen and then the rise of the arthritis. So yes, all these joint pains or joint inflammations will definitely impact your ability or your desire to do exercise, which again will have the secondary effect to essentially decreasing your caloric output and then making you more prone to gain weight.
Interesting. And and definitely I can see if you're having joint, muscle, and all these aches, I can see how your desire for sexual interaction might also be lowered because all of these things make for an uncomfortable situation.
Agreed.
So the good news is I don't think, I think there's things that we can do, right? There's things that people can do to sort of counteract that because, obviously in my line of work, we believe that human beings are sexual beings from cradle to grave, and we want people who want to experience their sexuality in all its forms as long as they can. And on that note, I just want to also point out, and I think this is a really important point about all these symptoms, which is these symptoms and lower libido, the correlation, in some ways it becomes like a self-perpetuating cycle, right? if you have sex and it's uncomfortable because you're having a hot flash or a mood swing or whatever it is, or it's uncomfortable because of vaginal dryness, or it's uncomfortable because of vaginal pain or infections, or there's an embarrassment, or there's disappointment because, maybe your partner is also aging, and maybe, male or female, their parts are not working the same as they did 20 years ago either. I think that it can become self-perpetuating in terms of desire and a lower libido, because if you're having negative, right, like sort of positive and negative reinforcement, if you're having negative reinforcement when you're having sex, it's going to lower your desire to do it, right? So we obviously want to help people counteract that. And before we get to some of those things that people can do, which is exciting, I do want to also point out there was a study, and this is so important to me, this is so near and dear to my heart, and it actually showed that women who believe, so this is sort of for everyone about to be on their perimenopausal journey, but women who believe that sexual enjoyment will decrease with age are twice as likely to have a decrease in sexual desire than women who don't have that belief. So if there's anything people take away, listeners, I'd love for people to take away that sexiness and sexuality does not have an expiration date. We are not going to buy into this idea that like our sexual desire and sex is going to be terrible as we age. We're going to counteract that, because as Dr. P is going to tell us, and as I have some tips also, there are things we can do to still find meaningful and satisfying sex way into our geriatric ages. So I think a big topic, a big buzz in the discussions of perimenopause and menopause is definitely hormone therapy.
Yes.
Like 20 years ago, there was this, it became like, you cannot do it, it's very dangerous. Now we're back on, we should do it. So kind of explain, what is it, kind of how did it get that bad rap, and why are we past that now, and why would you recommend it for certain people? All
right. I would start chronologically when this study came out. There's a WHI, and I think it was around 2001, 2002, did a big study essentially in women. They gave, I won't get into too much details, but they gave forms of estrogen and progesterone that we don't typically use anymore. And then they gathered the data and they saw, or at least they came to the conclusion, would be the appropriate phrasing, that it increased the risk of negative outcomes, breast cancer, cardiovascular events. And so at that point, it said, no, it is muy malo, very bad, do not touch it. And for the last, 20 years, not only were women taken off these hormones abruptly, but because it had such a bad rap, during medical school, we didn't really get that much exposure either. And so what happened was that we have essentially a 2 decades worth of women who have been, for lack of a better word, abandoned in terms of their care because of this. And nowadays, due to social media, I would say also due to more females in the medicine and healthcare, and then due to experts kind of voicing out their concerns, and the FDA also kind of being open to change these things, then we've had kind of a cycle back towards, yes, we should do it. And it's not kind of a blank statement, everyone should be on hormone therapy, but it's something that every female undergoing perimenopause and menopause should have a discussion about with their provider, whether that be their primary care physician or their OBGYN or their endocrinologist or their urologist, it doesn't matter. But have a discussion. And we know that in terms of giving hormone therapy during this time, and we'll just kind of focus on the menopause at this point, that giving women estrogen and or progesterone is very beneficial, both from a quality of life standpoint.
So women should not start it during perimenopause?
They can.
Oh, they can, okay.
They can.
If their symptoms are...
Correct. And so the idea in perimenopause, essentially, instead of having it like this, is to kind of regulate it so that it's a little bit more constant and you avoid those fluctuations. In terms of menopause, the goal is that you're here, and then we kind of want to increase it a little bit so that you don't have those symptoms, mostly due to estrogen deficiency. You have systemic estrogen and progesterone, and that's what's recommended for most women who still have an intact uterus. The progesterone does not need to be given if the woman does not have a uterus.
Oh, interesting.
And that is because progesterone, the main benefit is essentially to decrease the risk of endometrial cancer. It does have some other benefits, which women would say subjectively it improves their mood, it improves their sleeping habits, but then also other women say that it does cause a little bit of more mood disorders. So it kind of depends on if the woman kind of tolerates it or not. So the systemic therapy comes in either pills, which is probably the most common form. It comes in patches. It comes in creams, and it comes
Injections?
It does come in injections. We don't typically do injections, but it does come in injections, and I'm quite well versed with injections. I do gender affirming care, so I'm very knowledgeable about that. The other one, which we don't typically recommend, is the form of pellets. And so this would be combined estrogen and testosterone typically. In terms of why we don't recommend it, it typically leads to above normal or super physiologic levels. The other ones, we have pretty good data in terms of how effective they are, the pharmacokinetics of these things. And I'll kind of just focus on the one that's more typically prescribed, which is the oral one. So
that's a pill.
That's a pill you take in the morning every day. And then again, if you have a uterus, you can do a progesterone pill, typically given at night. Alternatively, you can do a progesterone intrauterine device or IUD if you don't want to take the actual pill of progesterone, and then you avoid the systemic effects of progesterone.
Is that like a regular IUD?
So it's a progesterone containing IUD.
But I mean, like, is that like Mirena? Is that the same
Yes.
thing? Oh,
Yes.
cool.
Yeah.
I already have one of those.
And
helpful.
And so the systemic estrogen will improve the systemic symptoms.
Got it.
So this is the brain fog. This is the fatigue. This is the mood disorders or irritability. This is the libido. So it can enhance sexual function. We'll kind of talk a little bit more about that later on. But all of these systemic effects of estrogen are noticeable. And the reason is because we, or women, have estrogen receptors mostly everywhere, right? Then you have the topical or vaginal estrogen. Topical or vaginal estrogen.
Like a cream.
Like a cream. It has many, many benefits with very little risks. So that's a good thing about it. So in terms of the benefits, it's that one, it's localized. And then two, that leads to a very decreased systemic absorption. So in women who are concerned about the systemic absorption or concerned about these side effects that they hear, then that is reassuring.
And so what does the cream do if it's applied it just helps with like the vaginal symptoms more?
Correct.
So it might not help as much on the mood.
Correct.
And kind of the other up here symptoms,
Yes.
but it helps with all your
With the
vaginal. So
genitourinary
like the
syndrome.
dryness, the thinning,
Yes.
the pain. Okay.
Yes.
So it's good to know. So someone maybe who's having more vaginal symptoms and less mental, emotional symptoms would be treated that way.
Correct.
And someone who's having more of the other, or maybe both, is a better candidate for the full-on
Correct.
oral treatment.
Yeah.
Okay.
So all of these hormone therapies, there's a recommendation in terms of what to use and how to use it, but it's always kind of individualized care. So you kind of have to determine what are the most distressing symptoms in this patient, what are their actual goals of therapy, and to kind of know which one to focus on. And so again, the estrogen vaginal cream is very good because it's very localized, and it will lead to an improvement in the thinning, as you said, but also from a sexual standpoint, it does increase the sexual pleasure. So this vaginal tissue, as you said, it's very, there's a lot of blood in it. So it will increase the sexual pleasure. It will increase the orgasms. So all those will improve with just vaginal. And the reason we're very gung-ho on this is because it's very cheap to give estradiol cream, even though there's other formulations that you can do it. It decreases the risk of urinary tract infections.
Oh, wow.
Right, as well. Yeah.
That's really good. And so, okay, so obviously a lot of benefits from hormone therapy, and that's something someone should definitely seek out with their medical providers, whichever doctor that might be. But there's also probably some things people can do on their own, right? Like, let's say someone's just not really interested in the hormone therapy, or maybe they want to try something more homeopathic first. So, obviously one thing that we always hear, I almost feel like it's told to us, no matter what the ailment is like, you just need to exercise or move more. But I mean, right? Like, it doesn't matter. You could go in with like a cold and they're like, well, do you exercise? And you're like, yes, right? Like, I mean, but there's reasons for that, because there are tangible proven benefits from physical movement, right? And so, if you could just like briefly explain sort of how exercise maybe can benefit, and we're not talking about, right? Like, you don't have to go do CrossFit for 3 hours a day. We're not talking about that, right? It could be something as simple as maybe walking if you're someone who hasn't really done even that. What are some of the benefits and how that can play a role in alleviating some of the menopausal symptoms and perimenopausal?
Yeah, so in terms of exercise, so the goal, as you said, is essentially just to move, right? We know, and one of the biggest stressors associated with perimenopause is the weight gain, right? So we know that it's a decrease in lean body mass, increase in visceral fat. So if you exercise, and by exercise we primarily kind of mean strength training, right? Where you actually put tension in the muscle so that you preserve or gain muscle mass. So that will help your overall metabolism or your basal metabolic rate. That will help you feel better. So exercise from a mental standpoint just helps you, right? Besides the physical.
Because it boosts all those endorphins, right?
Correct.
So you get like a nice little brain cocktail.
You don't. And so in terms of the other benefits, from a systemic standpoint from exercise, and in women in the menopause specifically, it will improve the bone density, or at least lead to a less of a decrease in the bone mineral density. So it's this idea that if you feel better, more than likely the other things are going to get better. From a muscle and adipose or fat tissue standpoint, we know that there is increased aromatization of these hormones if you have more adipose tissue. So decreasing that percentage of body fat will also help.
That's interesting. That's good to know. And, I did read something about mindfulness also. Like, obviously, from a medical perspective, that's probably less what you're going to be recommending to your patients. But I did read a study that basically said women who had a higher mindfulness score actually reported lower perimenopause and menopause symptoms, which I think is interesting. So obviously mindfulness, there's a lot of ways you can get into that. Obviously, like yoga, you can do meditation. There's all kinds of apps for people that are trying to increase their mindfulness. There's books, there's journaling. I think there's a lot of ways people can do that, and that might help. Another thing, obviously this is probably more my wheelhouse than yours, but I'm sure you recommend it for the women who are experiencing vaginal dryness, is lubrication, lube. Good old lube. It's easy. You can literally buy it on Amazon. If not, even at CVS, they have a giant section now of all different choices. So real briefly, we've got 3 different kinds. You got silicone-based, oil-based, water-based. Water-based is going to be generally safest for anything you need, but it does, it tends to dry out the fastest. You got silicone-based, which is safe for everything as well, but some people don't tolerate silicone as well. And you have oil-based, which you have to use caution with certain other types of prophylactics and things of that nature. But yeah, so there's lots of lubes available, right? I'm sure that's helpful to women, but not as helpful as the estradiol cream. I'm sure he would tell us, but
very helpful.
But another thing people can try. There's obviously, we're not going to get into this too much, but one thing that some women find success with is pelvic floor therapy.
Yes.
And we will have a pelvic floor therapist on a future episode, so stay tuned for that. So we won't dive into that too much. And then there's obviously what happens if you go through all these medical things with a patient and they're still like, I'm feeling better, but I still don't have any sexual desire. Like, where are we there?
We send them to you.
Exactly. No, that's right. Like, so in that situation, there might still be something more that needs to be explored. There's some kind of block that goes beyond the medical and the physical. And a lot of times that's what a sex coach, a sex therapist, other people would be able to work with. And also, obviously, I have lots of tips and tricks for people to spice up their sex life, find new ways to connect with their partner. And those will be topics of future content. So thank you so much for this conversation. Is there any last minute things you want to leave the listeners with that, like, if they take away one thing from today, it's what?
First, thank you for inviting me. This has been lovely. One takeaway for women that think they might be experiencing perimenopause or an overt menopause is, one, this is normal. This happens.
Yes.
If you feel that you are in this kind of range, feel more than free to talk to your provider. If you don't have a provider here in South Florida, I'm more than available. If you don't live here in South Florida, in the North American Menopause Society website, there are providers who are members, and then it will tell you their location so that you can go and actually see them. Know that there's people out there that take this very seriously and are available to treat you and will go alongside you in this journey for you to feel better.
That's excellent. Yeah, be your own advocate. If you go to a doctor and they're not taking it seriously, find someone who will. And I love that. And thank you for giving a resource to find that care. Thank you so much for being here. I learned a ton. Till next time, sexy besties.